I would like to hand it over to Praveen, who was the project lead of this entire testing system, and he will take it from here. Praveen, all yours.
Sorry, that I was on mute. So I'm hoping that you're able to see my screen here.
Yes, we can. Yes,
Okay.
we can. Please go ahead.
So this is, I mean, as Dr. Pramod said, primarily we are aiming, I mean, the whole objective of this testing exercise of the sandbox was patient workflows in general. With keeping in mind, I mean, the digital ecosystem, as you said, and then the building blocks that are currently available on the sandbox environment. So as far as the agenda goes, we will talk about the digital ecosystem, kind of give an introduction of what it is. We will also talk about the different building blocks that exist in the sandbox environment, and then focus on the workflow demonstration, starting with patient registration, starting with clinical workflows. We primarily picked a COVID patient and then followed through the journey of that patient from the fever clinic to inpatient admission and so on. So we will go through that process as well. We will also go through the consent process from a health information user perspective. So primarily we have the patient being admitted at the inpatient facility and they're requesting for records from the fever clinic. So we will walk through that process. And we will also walk through some of the clinical workflows based on the consent process. Finally, we will just touch upon some of the ease of use, intuitiveness of the applications that we have seen, and then kind of talk about the various findings that we have uncovered as part of this exercise. All right, let's proceed. So primarily, as you all understand, I think the National Digital Health Mission is an ecosystem, as Dr. Pramod mentioned, to create a digital environment for the citizens to own their own health record. And then there's also an ecosystem where they participate in different organizations and so on, and there are various caregivers and healthcare providers who are part of the patient journey as a whole. So to realize this particular community, I think we all, I mean, know that the digital health blueprint came into existence, and the NDHM also was built on a federated architecture where there are different management and data access across the country, and it's a federated architecture in that manner, where multiple entities are managing the health about the patient, and then basically the data exchange happens with multiple entities there. So we talked about, I mean, the digital building blocks, right? So what are those digital building blocks? Right now, as it stands, the health ID is the primary, identity for any patient across India, where the patient would be provided with a health ID by the government. We do have that building block in the sandbox environment. That is kind of the stepping stone for any patient to get into the digital ecosystem, right? So the next part is the health facility registry, where there are registries across the country who are offering healthcare services, and they need to be registered as part of this ecosystem. And the health facility registry is that part of the building block that is primarily used for that, to maintain a health registry across the country. We kind of briefly touched upon the consent manager and the gateway process. So primarily what this consent manager does is kind of manages the healthcare data interoperability between the different entities of that patient, right? Wherever the touch points are between the patient and the healthcare facility, the consent manager forms kind of the gateway to that process. The few last parts of the building blocks. One is the mobile application, which is on the front end of the patient. This is the application that the patient would use primarily to interact with different entities in the journey of that patient, right? Then we have the health information providers, or the health information users, who are either producers of data or consumers of data. So from a producer perspective, like all the healthcare systems across India, clinics, laboratories, pharmacies, all of them are generating health information at this moment. So they are categorized as health information providers. Also, we have another category called healthcare information users, who are primarily consumers of healthcare data, right? Like, for example, research organizations or hospitals or pharmacies or clinics across India or primary care health centers across India. So they are consuming that information. So they form the HIU organization there. Then we have the Digit Doctor, which is in the current state basically an authorization mechanism for doctors to own clinical care. And DigiDoctor in its future state will be a repository of all clinicians across the system, and those providers will play a part. And you will see that in the workflow when we go there. Right? So there are different building blocks which form the sandbox environment. This will again carry on to the NDHM domain when it's live and serving the country as a whole. Right. So we talked about, I think Dr. Pramod just kind of briefly touched upon the scenarios that we will be going through this demonstration. So here, so what we have done is basically we have a patient Ram Singh who is 54 years old, and he comes to a fever clinic. I'm not just going to walk through the scenario there, but we will touch upon this when we go to the actual EMR application. So primarily for this demonstration purposes, we have a patient here who visits the fever clinic. The registration happens through the patient registration happens through the web app, which I will be demonstrating in a few minutes. Then we have the outpatient registration through the EMR web app. And again, this is a reference application that NHA has created today. Basically, we use that reference application to complete our testing process. Then we have the outpatient record consultation. Then we have the diagnostic report, which is the COVID diagnostic reports. And then we have the prescription for the patient. Right? So this is the typical workflow of the patient who's visiting a fever clinic. Ram Singh gets diagnosed with COVID-19 positive, and then he's actually admitted to Tata Memorial Hospital in the COVID care center, right? So there are a series of events happening on Ram Singh, and then the Ram Singh apparently is admitted there in the COVID care center. So we will walk you through the inpatient registration process where Ram Singh is admitted. There's a consent process where Tata Memorial Hospital is requesting for medical records from the fever clinic. Then the PCR test is done at COVID care center in Tata Memorial Hospital. Ram Singh is found to be negative at that stage and discharged home. So this is the typical scenario that we are going to follow. And we will basically complete the outpatient visit, move on to the inpatient visit. We'll complete that workflow there, and then come back and see how the records appear on the PHR mobile app. All right. So primarily, as Dr. Pramod alluded to, and the reference implementation that we have. So I just want to spend a few minutes here. So our primary evaluation of the sandbox environment has been based on the reference EMR that NHA has created at this moment, right? So we haven't done the results from the application programming interfaces, which is another mode of accessing the sandbox environment. We will be presenting those results in a later session. So right now, the feedback that we have, the testing process that we have conducted is primarily based on the reference EMR that NHA has put together at the moment, right? So as I said, I mean, all the building blocks actually are in this reference architecture. So we have the HIPs here, which are hospitals, diagnostic centers, clinics. Then we have the reference EMR, which we will be demonstrating, which is the app that NHA has provided right now in the sandbox environment. Then we talked about the consent manager process, the DigiDoctor. Facility registry is still not up. It is only available right now at the Union Territories level, but it will be available across India at some point. Then we talked about the consent process. Primarily, in this case, it will be from Tata Memorial Hospital requesting for records. And we will see the whole process of that consent coming back to the patient, and then how that patient authorizes the consent, and how that HIP is able to see that consent, HIU is able to see that consent which was requested from the patient, right? So now we will basically move on to the demonstration process. So what I will do is basically walk you through the process of patient registration through the PHR mobile app, and then we will move on to the EMR, the reference EMR that we talked about, and then Ankita will take over from there and then explain the process of how the patient is created, how the patient flows through different care settings, and then we will move on to the HIU side. So for the patient registration process, I'll have to basically show you the patient mobile app, which we talked about. So this is an Android app. I'm actually using an Android simulator here to show you on the web. So this is the app that is currently in the Sandbox environment. So the primary purpose of this app is for patient registration process. So the health ID is actually generated from this app, as well as various other sources. There's also a website where you can actually create your health ID. This is one mode of creating the health ID. If you have an Android phone, you can actually use this Android phone to create your patient ID. So let us walk through the registration process first, and then we'll come back to logging into a sample account here. Right? So if you click on this register button, you will be asked to basically enter your mobile number, which is one form of the authentication to access that you're a valid patient and so on. So once you enter your mobile number, it's going to authorize, basically validate your mobile number and then send an OTP. So the OTP is being sent to my mobile phone here. Okay, so I just received the OTP on my mobile phone. So just want to enter that. I had registered a new patient, okay, and then it basically sent OTP to my mobile phone. I've entered the OTP, and then this is the landing screen next to it. Okay, so the health ID process has actually two forms of authentication. One is through the mobile phone, right? The second process is through the Aadhaar number. Again, this is an optional setup. Again, currently, as the Sandbox environment stands, they have basically enabled creating health ID using multiple forms, multiple authentication. You can actually proceed without giving Aadhaar, and we will show you where that appears. So these are the primary registration patient demographics that are currently available in the Sandbox web app. So basically, it will request you to enter your first name, which is mandatory here. The middle name is optional. Last name is optional. The date is required. Again, full date of birth is not mandatory, while only the year of birth is mandatory. So the gender is mandatory. You have to select among these options. And then the address and the state or the district is mandatory here. So basically, they don't ask you for a full address, but right now, as it stands today, they ask for the state and the district information. And then once I agree to the user information agreement, which is part of any website, you will be able to register your website. You'll register your health ID. So what it does, basically, let me go back. So we already have a patient who's linked to Ram Singh. Can you guys see my screen now, or still not?
Yes, we can.
Okay. Okay, so those who are not seeing the screen, I think as Dr. Pramod said, please pin your screen. I think you'll be able to see that screen there. Because we are switching between the PowerPoint and the mobile app. So that's the reason, I think. Okay, so I think everybody got the registration process. So basically what it does is, let me log into the test patient that we will be using. And then I'll just walk you through the different process and then hand it over to Ankita, who will do the EMR part. Okay. So once you create the health ID, it's going to basically land up in my health record. Initially, it will be totally empty because you will not have any records to pull in. If I go to the profile section, so once you create a health ID, it will actually generate this 14-digit health ID number, and which is unique. And then there's also a health ID that you can pick when you're creating an account. So I picked whatever it is at SBX, which is the Sandbox environment. So you have some personal details. And then also you have to create your consent PIN. which we will talk about when we go through the consent process. So you'll have to enter the PIN when the consent request comes in from the HIU. Okay, so basically, as a phone PIN or like an ATM PIN, you have to basically create a 4-digit PIN here for the consent, and you will use that when you authorize your consent request. Okay. So this is how you created it. So there are 3 different sections here. One is for the health record here. Then you have a provider section. So basically, when you go to, whatever hospital that you go to, the patient will have to add that particular facility here. So right now we have the reference EMR, which is our test facility that we have added here. And then we have the consent tab where you could see all the active consents, right? So this is the app. We'll come back to this. Now I will stop sharing, and then Ankita will basically walk you through the process. So primarily what we're going to do is taking that COVID scenarios that we talked about. So the patient goes to the fever clinic, then the patient is admitted to the inpatient facility at Tata Memorial Hospital because he's found to be COVID positive, and then we will go through the discharge process. Right. So Ankita, I will stop sharing. You can share it.
Yeah, so thank you, Praveen. So this is the EMR system where we'll do the patient registration for all inpatient or outpatient visit. Okay, so let me log in first. So this one is the EMR home screen where patient registration and health ID creation both can be done. So if the patient doesn't have health ID, so health ID can be created using this link. And if the patient has already has the health ID, then he can directly proceed with the registration for the visit. So let me show you the patient registration screen. So this is the patient registration screen where the patient can be registered either for inpatient or outpatient visit. So as the patient already has the health ID, so I can use the health ID over here, verify. So this means that the health ID exists in the system. So I'll proceed with the patient registration. Here, first name is mandatory. Then gender is also mandatory. And these are the basic demographics details which is required for the patient registration. And once we provide the demographics detail, then we need to select the visit type, whether that visit is either inpatient, outpatient, emergency. So we can select any visit and then submit it. So this will complete our patient registration process. And as we, based on our scenario, we have already created the visit. So let me walk you through those visits. So this one is outpatient visit, which we created earlier. So the patient has visited the fever clinic with suspected COVID-19 symptoms. So here, all details will be filled under OP consultation note. Let me show you up the recorded details which we have filled over here. So this details was recorded during the OP visit. So here, past history, then symptoms, vitals, observations were recorded, and the diagnosis was provided based on the initial assessment, and then the treatment plan, whatever has been planned for the patient. And along with that, prescription medications were given to the patient. Same day, PCR test was performed on the patient and lab results got uploaded on the system after 2 days. So this is the diagnostic report section where we can upload the lab results. So I'll show. So here we have uploaded the lab result with COVID-19 positive result. Once this is done, Then after 2 days, the patient has visited again to COVID care center because he got a positive result. So here the COVID care center can pull up the details from the fever clinic. And here after admission, after 7 days of admission, then again we did the PCR test where the result was negative. So we can upload the results under diagnostic result section again at COVID care center. And on the discharge date, then the discharge summary got uploaded for the patient with all the details, all the inpatient details. So here date of admission, discharge date, then the complaints, presenting complaints, whatever the patient was having, diagnosis COVID-19, procedure performed. So on seventh day of admission, repeat PCR test was done. So whatever treatment or medications has been given to the patient, so all those things are mentioned over here. Then the status of the patient at the discharge and advice on the discharge. So if reoccurrence of fever or cough, then he can consult the doctor again. So same discharge summary has been uploaded on the patient visit section. So this completes the patient outpatient and inpatient flow both. Now I'll hand over to Divya for the consent flow. So Divya, can you please take over from this point? I'll stop sharing. Thank you,
Yeah,
everyone.
thanks, Ankit. So now that our patient Ram Singh has to be admitted to a hospital, Tata Memorial Hospital. So from there, we want to request for his medical records. So now we are creating a consent request for Ram Singh. So on creating a for the request, these are the fields that we'll have to enter. Okay. So one here we have to search for the patient. Okay. So it search for the patient and the purpose of the request. So these are the purposes, care of management and the rest. So we choose care of management. Okay. And the health records since when we want it. So we chose somewhere around 15 September till date. Okay. And what are the types of health records that we want it? So we choose for the OP consultation, diagnostic reports, discharge summary, and prescriptions. And this is the consent expiry. So till when this consent can be valid and till when he can grant the access or take any actions. So these are the things. So the request is sent from the Tata Memorial Hospital to the Ram Singh here. So on request, we see that the request has been initiated. Okay. So once this is done on the PHR, maybe Praveen will take it from here and he will show you how we accept and take the rest of the call. Praveen, can you take it over?
Yeah. Thank you, Divya. So as Divya said, basically, we are requesting, Tata Memorial Hospital has requested for the records of Ram Singh, right? So now the request comes in to Ram Singh as a patient. So what we will basically go through is, initially when we talked about the patient creation process, right? I talked to you guys about the consent pin here. So there's a specific reason for that. Okay, so when you create a profile, you have to create a consent process. So the consent has been raised there. So what happens is once Ram Singh logs into his PHI mobile, again there's a notification that comes in. I'll not be able to show that, but primarily when the consent request is raised, there is an SMS which gets sent from the required hospital. So the SMS comes to the mobile phone. Okay, and then basically Ram Singh logs into his PHR mobile app. So you see that the request has come in, just the request that Divya has just entered, right? So we will process that request. So basically to process that request, like to click on that request, and as she entered, Tata Memorial Hospital is requesting the record for the purposes of care management. And then this is the dates that she had requested for, which is 15th September to the 4th October. And these are the following types of information that she requested. She requested a diagnostic report, she requested the discharge summary, consultation report on the prescription, right? And then she did enter a consent expiry period. So the reason that consent expiry is available is that this is the maximum time that the patient is required basically to approve the consent or grant the consent. If it exceeds beyond this point, this consent will disappear from the list. So that's the primary reason for the consent expiry. Right? So basically what I do is either deny or grant the consent based on the request. And then once I grant the consent, it actually asks you to enter the PIN, which is the PIN that we initially set up. So I enter the PIN and then I confirm the request. The request now has gone back. Right? So now the request is approved. And then it has gone to Tata Memorial Hospital, right? So this is the entire workflow. So primarily what we did is, just to recap the workflow, we basically had Ram Singh, our patient, who was kind of suspected COVID patient. Then he goes to the fever clinic. Then the fever clinic basically diagnoses him, does all the required test, which is the PCR test, then prescribes him medication, ask him to go to home quarantine, right? Then the results come back after 2 days, the PCR results. Then the result is positive. Now the patient needs to get admitted. So the patient is getting admitted to an inpatient facility. The inpatient facility is Tata Memorial Hospital. They actually request for records. The records come back from the patient, from the fever clinic. Then they actually do the treatment for that patient for COVID positive. Then they do a PCR test after some time. It is found to be negative, then the patient is discharged home with medications. So that is the workflow that we just showcased, right? Yeah, I just wanted to show them the consult report. Again, there is an issue currently with the app. So we will just show quickly on how the consultation report on the discharge summary report appears on the patient side. So I am a patient, Ram Singh, who's logged into the PHR app. If I open the consultation report, all the details that are entered here are appearing here. The symptoms, the observations, the diagnosis, the treatment plan that we entered, the prescription details, and so on. Similarly, on the discharge summary, the inpatient visit, the chief complaints, the final diagnosis of the patient, which was COVID negative, which is the reason why they discharged the patient. The procedures that were performed, which is the PCR that they performed after 7 days, the medications that the patient was asked to take after discharge, the care plan for the patient, which is the Bicocil tablets that was prescribed for 10 days, right? So this is how it appears on the patient app, right? So once the record is completed on the provider side, the health information provider, that gets actually pulled into the patient side, and this is how it appears, right? So Dr. Pramod, I'll just quickly touch upon some of the basic points that we have seen through this. Are you able to see my screen now?
Yes.
We have the presentation right now open. So I'll just quickly demonstrate, or basically walk through the different observations that we have had. So one is, I think there is some ambiguity in some areas, in some places where we have date of birth, last name, addresses. There are some fields which are mandatory, some fields which are non-mandatory. Again, from a clinical perspective, there might be some reasons why that is done. Also, there is a lot of information which is being displayed right now on the clinical context, which I think Dr. Pramod will probably go through that stuff. And it is helpful for the doctors in this meeting to go through that process. There are some incomplete medical records that we have seen, especially when it is pulled from the HIP perspective, and Dr. Pramod will probably touch upon that. As you see in the EMR side, there are multiple workflows being combined. The way I tell that is basically we have the clinical workflow, the nursing workflow, the lab workflow, the radiology workflow, and so on. And if you see the reference web application, it combines all those different workflows together. So there's no separation in terms of roles and responsibilities from a clinician perspective, from a lab tech perspective, or imaging tech perspective, and so on. So that's all combined together. Again, medical records we have seen, I think we'll probably see that in a few minutes, that it's not clearly formatted from a clinical perspective, right? For decision making and basically treating that patient, we don't have that clearly formatted at this moment. Right? Then there's also incomplete data from the HIA perspective, right? Then we also saw about the standardization in templates, where there is a different template being followed across the system. So that needs a little bit of cleaning up and so on. So Dr. Brahma, I think I'm done from my side. I will stop sharing.
Okay. So I will take over from here, and a few more slides for everybody, and I'm going to speak on a little more from the clinical aspect. Give me a moment here while I share my screen. So what I will talk about is the review of clinical components and the patient flow, workflow, and the impressions. Now, this is the OPD consultation note which the consultant or the doctor will use. We are concerned definitely about this upload scan OP consultation notes. That means there is a back door for folks to write or handwrite, or in free text form scan a document and send it up. I understand that it is a necessity right now, because maybe in the rural and semi-rural areas that you may not have digitization or may not be possible, but we strongly recommend that this be an exception, case by case, and I will explain to you why. The second aspect we found from physicians or doctors' point of view, this was a little confusing. They have history, one tab, and then they have symptoms. Now, what do they mean by history? Because normally in India, when you say history, okay, in India, the way that you do a medical consult is you take a history, then you do the exam, you come to a diagnosis, and then you kind of carry out the plan that you want to. Now, does this history mean the past history or the family history and stuff? Or does it mean that it is actually the history where I put the history? If that is so, then why do I have another tab that says symptoms? Okay, this is a bit confusing. Anyway, now I'm going to the next slide, because here I am showing you, okay, a friend of mine in my colony had a little issue with his health, and he showed me this ECG which was taken in the past. I've taken off all the patient identifiers or any identifiers. What I want you to look at is the report that is written on this. Okay, and mind you, I was legendary for my bad handwriting. So much so that, in medical college and all, when we used to go for the Chinese dinner and the noodles used to come, everyone used to say, "See, Pramod, that is your handwriting." Even I could not make out head or tail of this. All right, I was just completely, except for an LAD, I cannot make out anything else. So then I asked my friend, "Please, can you go for another ECG and this time tell the doctor to clearly write the report?" Okay, this is what happened. The next visit he went. Okay, I just again cannot make out. All I can make out is LAD. I do not know what else is going on there. So then I asked my friend, "Please, before you pay him, ask him to write this out on a piece of paper in block letters." And finally, this is what it meant. I don't think I have to say anything more. Okay, you can use optical character recognition, you can use sort of natural language processing, you can use unnatural language processing, you can use supernatural language processing. It will never be able to decipher what was written here. I can guarantee you that. Okay, finally, when you see what the whole thing writes, that is a left anterior descending artery and the incomplete right bundle branch, etc., etc. All that was actually put into this little bit that is, you see here. Data quality, things like this make errors, medical errors, which can be fatal. I am not saying anything about anyone. It is because we have so many patients per doctor, we might be being forced to write like this, but this is a very common scenario in our medical records right now in the paper world. And if you scan such sort of documents and upload it, there is no way any analysis or any meaningful data mining can happen, which will benefit our health ecosystem and our citizens. So that is why the concern that please the scanning of documents uploading should be minimized and case by case exceptions only should be allowed. Okay. Now what we do is we are looking at the input of the various documents that's going in. What I'm going to do is I'm going to first look at the screen that where you put in information, and then I'm going to look at the output that comes out. So one thing we noticed like this, of course, there is also an OPD consult and all, but in the discharge summary, for example, you have places for putting in the complaints, but where is the place for putting in the exam, right? You can put in the diagnosis. All this is all okay. We are fine with that. But you need to put in a place for the exam also. Physical exam is very much part of also the discharge summary that is written up. What was his examination finding at admission? And, possibly what was it at the time of discharge? It's also known as course in the hospital. Now, one thing which is very, very encouraging, that even though that data was input at a given hospital in Mumbai, Tata Memorial, when I went, or whenever this patient, Praveen, or actually Ram Singh went back to his village and went and met his doctor who happened to have a digital connection, he was able to pull out that record digitally. It's a very, very big plus. That is interoperability at play. Okay, so something to be very encouraged about. There are some issues which I will go on to. For example, now I'm comparing what was put into the by the doctor and what was showing up in the discharge summary. Certain aspects are there which we have to be, just correct. Not a very big deal, but can be and needs to be addressed. For example, date of admission, all that is fine. It's all coming there. Now, presenting complaints with duration, fever, and so on. This has been written up here. What you will notice is that it comes under something called chief complaints section, but under something called condition. In India, when they see a chief complaint, most doctors understand that to be what was the complaint the patient told the doctor. Okay, when you see a thing like condition in the output, but one thing you must understand that there is a particular, this condition actually refers to a FHIR terminology, which is, FHIR, which is basically fast healthcare interoperability resources, where condition refers to a diagnosis. And this is really because we are using the, sorry, I've got a call here for some reason. What is that about? Is there, anybody can hear me or not? Okay. Praveen, all that is okay? Am I being heard?
We can hear you.
Yeah.
Okay, then please, I'm going to ignore that call. Okay, so what happens is, but there is some very good news. It's just a question of mapping. It's not a very big deal. You see this part here saying severity, unspecified, clinical, unspecified, and all. The moment we saw this, we were very happy. Okay, maybe, it has not come in the correct place, but I'll tell you why we were very happy. It shows that there is a particular container which is being used to transport this information from one place to the other, which is the FHIR artifact, right? That has already been put in place. So if you look at the FHIR resources and how they define it in condition, which is basically, if you see here, condition is equal to diagnosis. That's what they, in the US, they call diagnosis, problems, and so on. They have these required fields, right? For example, they have this field called clinical status, where you're supposed to be able to put this, one of these choices. And like this, they have these other fields also where you have required and you have to put in a choice like that. Now, of course, we have to revisit and see whether in India we really need something like this clinical status, like inactive remission and all. In the US, this is very, very relevant because the billing depends on the fact whether the patient was readmitted or whether it was a first-time admission, etc. But in India, we'll have to revisit that. And if it is not required here, maybe we have to consider taking it off. That is something known as profiling for India, Indianization of these sort of resources. Okay? So next thing you will notice is that while the diagnosis has come in correctly saying COVID test negative. Of course, all this is because this has not been. If they're asking us to fill this, they must also have a way where we can put in what is the severity, what is the clinical status, verification status, and so on. Not a big deal, even if it is empty, never mind. We know at least it is being carried by a standardized container, a standardized messaging system, and makes us all very happy. Procedures performed. We did perform procedure. It did not show up in the output. Again, it is just a question of a little correction, a little bit of, print groups have to be brought in or whatever it is, and I'm sure that can be easily corrected. And finally, in the next screen, I will just show you that you print medications that showed up here. Very nice. And then, certain things. When we did the status at the time of discharge, it did not come up in the sort of output. But never mind. And even the discharge medication somehow did not come up. But these are all things that can be worked out. Anybody who has been in the IT field knows that when you first put up systems, these are small matters. There is some syntax or some small correction which will have to be done and can be very quickly corrected. Okay. So what I want you all to understand is, what were we very worried about when they first talked about this system coming up as an ecosystem? We were very worried they would go the US way, and I am showing you a US EHR system. Okay, this is open EMR, which is a open source EMR system from the US. A doctor in the US, every time he sees a patient, has two main headings that he's got to face. And ironically, it is the administrative one, which is the billing one, that is presented to him first. Okay, he's also got, of course, the clinical side, but the administrative side is a very big side that he's got to fill. And this sort of data is supposed to be actually filled in by the doctor. All right, saying what sort of a diagnosis, what sort of a procedure code, etc., etc. They spend a lot of time on this because they reconcile this with their notes. This is the SOAP note, and they keep reconciling between the two. What do I mean? There is a system known as E&M codes, evaluation and management codes. Okay, in an OPD visit, you are paid depending on how much of these details you put into your record. So somebody who's putting in say a follow-up visit is expected to at least do so much, spend 10 to 15 minutes putting in problem focused or extended problem focused. If he's seeing a new patient, he's expected to be detailed and so on. And comprehensive is very complex. So for example, in history, problem focus would be saying family history. I have asked him whether he has any family history of any diseases. All right. But in extended problem focus, I will ask him, did your mother have a problem? Did your father have a problem? Did your brother have a problem? Like this, you will keep detailing that out and saying yes, 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 or no, no, no. That is what they mean. And this is a checklist like they use for the claims process. Fortunately, our folks who have come up with the National Digital Health Mission platform has gone the correct way. Okay. So here are my impression. The glass is more than half full. Let us be positive. Okay. Because the paradigm that they used was that the building blocks they first put up were the patient flow and clinical flow, not the claims and billing. If you had known the first Ayushman Bharat system, what they had done is they had first gone for claims and billing and then added on all the clinical flow and patient, basically clinical flow aspects to prove that claim. But this time, they have gone the correct way as far as what we can perceive. They've looked at patient, and then they looked at patient's interactions with the doctors and the clinicians and so on, and the record, actual making of his record, which will help in the continuity of care. And down the line, then they will, I think, come up with the claims and billing building blocks. Second question that we all had, will they have digital health standards? By the fact that they have the FHIR container itself shows that they have already put the basics of putting in the standards in place, because they have the container in place which can be filled in with the correct standards and terminologies. Secondly, when you are putting in a medical result, a diagnostic result in the present system, there is a standard that you have to use. It happens to be SNOMED. It should be LOINC. That is something that we corrected later. Okay. So what would be the next step? So impression wise, we have, I would say, glasses more than half full. Okay. Now, all we need to do is you work closely between our folks in the government and our digital health as well as the health community, the end users. If we work closely together and we start looking at Indianizing the fire profiles and artifacts, incorporating the standards into the, into the, at least the messaging systems, okay, and then making it such that a hospital has a choice of, at least if he's standard compliant, being able to send this complete details with the proper standards in place across, or if he's not, then he can do scanning and so on. Okay, and then we have to now move on to the other aspects, naturally the other building blocks for claims and billing, because finally you have to be paid for a service. And sure enough, that has to also come up. And then, of course, all the rest of the sort of, ecosystem, which will involve a health exchange system and so on. Okay. Basically, if we all work together very closely, I am pretty confident in a month or within less than a month, we can at least have a good enough national digital health system with adequate testing and scenario run-throughs done. Sorry, it should have been run-throughs. I made a spelling mistake there. And I'm sorry, why is that? Okay. Something is wrong. I just, give me a moment here. So anyway, let me just go to the last slide and give my last impression. Okay. Once you have done this, if you test pilot and demonstrate the national digital health ecosystem to the satisfaction of associations of end users, like for example, Indian Medical Association or the CAHO, or CAHO, and the hospitals and doctors, and prove to them that this is working. You take one district or one given hospital through and through, from the primary to the secondary to the tertiary and back. Demonstrate it, and I'm sure we'll be able to bring the community together, both the healthcare community as well as the government, and make that public-private partnership work and pull in the same direction and make this work. Thereby, hopefully, improving our situation in the pandemic and in the future for the continuity of care and for a swasth